Now let's discuss TURBT. Before how to perform if a patient present in your PT and you performed all investigation and you reach to the conclusion that the patient is having a bladder growth on ultrasound or in your office flexible cystoscopy. So now the time to perform TURBT. So how to perform TURBT? What will be the position of the patient and how to establish the clinical and pathological diagnose. So after proper explaining the condition to the patient, their proper consent, and after that we will check the whole WHO checklist that is complete or not complete. Then we will go for bimanual palpation under anesthesia, and if there is a palpable mass in the unpalpation, it means that the tumor is muscle invasive. And then again we will be performing the bimanual palpation at the end of uh, surgery, because the presence of mass at the end of the surgery, that's well our final staging. And if again at the end the mass is palpable, it means that the disease is at least T3, means that it at least involving the perivesical tissue. So it can be at least T3. So by manual examination, and there is a one classification for this by manual palpation, that is called Marshall classification, and they tell us about the clinical staging of the bladder growth during TURBT. That's also important. So it's the clinical staging is the one which is at the end of bimanual examination. At the end of the procedure, when we are going to perform bimanual examination, that's our final clinical stage of the disease. So bimanual palpation is important. Then we will perform a full diagnostic cystoscopy with continuous flow resectoscope in order to document the number of a tumor, the size of the tumor, the architecture of the tumor, the location of the tumor, and any concern for the presence of CIS or recurrence versus primary tumor. So we will document all these things. Now coming to the surgical technique and which water you will use. So all these important. The surgical technique for resection include piecemeal resection and en bloc resection. Piecemeal means to take in fractions, separate resection of the exophytic part of the tumor, then the underlying bladder wall, and then the edge of the resection wall. This also gave a very good information about the vertical and horizontal extent of the tumor, and we usually performing this with routine the loop diathermy. Loop diathermy can be used with monopolar or bipolar or with a laser. And then coming to the en bloc resection. In en bloc resection, we using monopolar, bipolar, loop resection, or we can use laser. But what's the difference between en bloc and piecemeal? En bloc provide high quality resected specimen with the presence of detrusor muscle in 96 to 100% of cases, and the resected respect of the tumor architecture increase the accuracy of T1 staging. So it, and another important thing, that it's reducing the risk of bladder for. And which kind of irrigating fluid we can use? We can use glycine, we can use normal saline, and we can use sterile water. And if we are going to perform monopolar, we are using glycine, that's standard. But we are using bipolar, we will be using the normal saline, because if we use the normal saline with the monopolar, that will cause a conducting current, and our current will disperse in the bladder, so it will not a good giving a good resection. So for monopolar we will be using glycine, for bipolar we will be using the normal saline. We can also use for resection during Turbt the sterile water can also be used, and it's mentioned in Campbell. Now if a bladder growth is located at the posterolateral aspect of the bladder, so what can happen? The obturator kick or obturator jerk can happen. Why? Because the obturator nerve is located on the posterolateral aspect of the bladder wall, and if there is a tumor at the posterolateral wall, our current can stimulate the obturator nerve, and that cause the obturator kick or spasm. How this can be prevented? This can be prevented by continuous underfilled during resection, means don't pull the bladder to the level that it will cause the obturator block. Other mechanism like reducing the voltage on the diathermy can reduce, then using the bipolar or laser can reduce the risk, then spinal with obturator block can reduce the risk, then general anesthesia with muscle relaxation can reduce, and reducing the diathermy current during the resection can reduce the risk of jerk, reduce bladder filling, and a possible in block resection if the tumor is less than 1 centimeter. That can reduce the obturator cake. The root value of the obturator nerve L2, L3, and L4, and if it is injured or stimulated, it will cause the leg adduction, leg abduction, and the sensory loss of the middle side of the affected site. And how it can be given, the obturator nerve block, it can be given by blind technique with nerve stimulator or ultrasound guidance. And the technique involved that the patient will be in a supine position with the ipsilateral leg abducted at 30 degree. Then we will insert a needle perpendicular 1.5 centimeter caudal to the pubic tubercle. That will cause stimulation, and this stimulation we will inject lidocaine into the nerves. So this was asked in short case, and this detail was actually for short case also.